Hey, Leah.
Hey, Fallon, and hey, listeners. We are the hosts of a podcast called The Secret Life of Canada. We are a history podcast.
Yeah, and we've covered topics, things like the gold rush or the Bay blanket.
Yes, kind of unconventional stories, though, that you might have missed in your Canadian history class.
So we're here to uncover those secrets.
That's right. Check us out wherever you get your podcasts.
This is a CBC podcast.
Time for Ask Me Anything with Dr. Gerald Evans and Professor Raywat Deonandan.
Ask me anything!
Is there any evidence for transmission of the SARS-2 COVID-19 virus from empty beverage containers to recyclers?
How close are we to actually having a vaccine?
If both people are wearing masks, what are the chances of transmission if either of us have COVID?
Well, I am getting AMA questions on every medium that I have. It's on paper, it's on the computer, and I know we're going to get some callers as well. We're joined once again by Dr. Gerald Evans, Chair of the Division of Infectious Diseases at Queen's University and the Medical Director of Infection Prevention and Control at Kingston Health Sciences Centre. And Dr. Evans is in Kingston. We're also joined by Raywat Deonandan, an epidemiologist and associate professor at the University of Ottawa. And that's where we've reached him. Professor Deonandan, hi.
Hi, how are you?
Good. And Dr. Evans, you're still there?
I am indeed.
All right. So many questions. Let me begin with one of them that we got in on social media. And you can decide, who wants to answer this. Regardless of what we reopen first, bars, schools, whatever, what level of community testing for COVID-19 is necessary to chart the spread, and how close are we to having it now? Dr. Evans?
It's very important to continue our testing simply because we need to track. One of the most important measures that we want to track, actually, is the speed of the increase in new cases. The slope of that curve tells us a lot and tells us when we should be thinking about plans to sort of slow things down, ramp things down, and then when that falls to ramp it up again. So the biggest problem with testing is that we really want to test lots of symptomatic people. We do want to do some surveillance testing, which is sort of generally in the population. And Raywat may have some more comments about that as an epidemiologist, but it is still important to do that sort of testing so that we always have a kind of a snapshot of what's happening in the community, and recognize that, the testing we currently do is just a snapshot in time. It tells you the day that person was tested, whether they were positive or negative. And there's all kinds of weird statistical things that go on when you test low prevalence populations, which again makes it probably beyond the scope of further discussion, but certainly is challenging.
Professor Deonandan, how are we doing on testing?
Well, we're doing okay, and there are at least three metrics that we care about around testing and navigating our way through this crisis. The first, as noted, is the number of new cases we identify per day. We like that trend line to be flat, if not diminishing. The second is this thing called the reproduction number that Dr. Evans had referred to, which is the average number of new cases that an O case produces, and we like that to be 1 or less. And right now across Canada, it hovers around 1. And the third is the percent of tests that we do that come back positive. We want that to be as low as possible. Across Canada right now, it's under 3%, I believe, or hovering around 3%. We know we're doing enough testing if that percent of that last number I mentioned is like 10 or less, because we don't think the prevalence of the disease is as high as 10. So right now in Canada, we're okay. If you look south of the border, they're not so okay. And all those three metrics are trending in the wrong direction. So to answer the question directly, testing is everything. It's our primary tool in navigating through the rest of this pandemic, and we can't take our foot off the pedal.
And Professor Deonandan, you've recently written about how to safely open schools. This is a concern to so many people. How do you think about opening of bars and restaurants, what effect that may have on our plans to reopen schools?
Oh, that's a perfect question. And I think 100% of our focus through Public Health Lens should be right now on how to open schools safely in the fall across Canada. And anything that distracts us from that goal is a disservice to the ultimate public health outcomes that we care about. So The primary way, the best way to open schools safely is to keep the incidence of the disease as low as possible in the community. If it's not in the community, it can't get into the schools and it can't get into people's houses. Opening bars does not keep the caseload low in the community. It's as simple as that. I prefer for us to focus on those essential services that we need to maintain our mental health and to maintain our economic health. A bar, while I love bars and I miss bars, I understand that people have jobs to do at bars, they present for me too great of a risk right now and too little of a reward, especially when it comes to potentially increasing the caseload such that we cannot open schools in the fall. And that should be our number one priority.
So is that an answer that's based on the experience in particular places like Toronto and Montreal, or do you think that you feel that way for all places across the country?
Let's look at Sweden. So Sweden famously only had a couple of rules that they wanted their citizens to follow. And one of those rules was no standing up in bars. So even Sweden, the capital of the lackadaisical approach to COVID, understood that bars are a major threat. So if you look at other places in the world where the disease has reasserted itself, we look at South Korea, for example. Famously, an outbreak occurred when one gentleman went to a couple of nightclubs. We look at Montreal, where a bar was shut down because of explosion of cases. We look at Florida and Texas, where bars were the major avenues for the reassertion of this disease. It seems to me that that's telling us something. It's telling us that bars are a dangerous place to play with as the economies reopen. That's not to say it can't be done. It can be done with the appropriate public health measures put into place. I'm just skeptical that it will be done with the appropriate rigor and vigor and oversight, because I'm feeling skeptical today with not a lot of faith in humanity. And I see as alcohol starts to flow, people are less likely to take this seriously. And again, the focus should be keep the caseload low so that we can open schools and keep the economy open.
Yeah. So back to the school issue, Dr. Evans, we keep on hearing that the kids are at a lower risk of getting the infection, of spreading the infection in a school setting. Is that still the case?
Well, there's some great data that's come out recently. One of them was actually a study that was just in preprint this week from South Korea looking at contact tracing, and they were able to actually identify that smaller age or lower age children represent less of an issue than older children. So there's almost certainly a difference even between elementary grades and the higher grades in secondary school, where adolescents seem to transmit as readily as adults do. And part of that, there's at least a little bit of a biological plausibility to it, in that the receptor that the virus uses to attach in the upper respiratory tract is actually expressed a lot less in younger children, and as we age, it becomes expressed more and more. And so some of this sort of age gradient that we're seeing may be explained at least on a biological reason. So I think there's a lot of I couldn't agree more with Raywat what he's saying. He's bang on with this, and I made the same point about schools. We really need to be concentrating on them. I think that's where our efforts, our thoughts, our work, and our progress needs to move forward, because that's just absolutely critical to our society in general.
And Professor Deonandan, any statistics at this point? I know it's early in this pandemic, but that could give us some guidance on how the virus spreads, doesn't spread, can be restricted in its spread within the school setting?
Well, I'm familiar with the South Korea study that Dr. Evans just cited, and I'm hesitant to take a lot away from it because it's wrought with some biases that are typical for large studies like this. For example, it's possible that a teenager might be part of a super spreading event. One 18-year-old might spread to like 20 people in his extended family, and that skews the data a certain direction. I will say, though, that we know that children, regardless if they are less likely or more likely or not, or no change in difference in likeliness to get the disease or spread the disease, children tend to have a lot more contacts than adults do. So it kind of washes out in the long run. So an adult sees, 4 or 5 people per week, typically, because we're boring old people who have office jobs. But a kid will see up to 100 people per week because they're social people who are interacting all the time. So even if their risk is low for getting and transmitting, their risk is high for interacting with a number of people. I'm very concerned about what to do with children. And it's not like they're immune to this. They have a lesser likelihood, an extreme lesser likelihood of having a bad reaction to this disease, but they do die. right? We have cases of children dying, and that's horribly tragic. And if something were to happen like that in one of our communities in Canada, there would be an enormous reaction, appropriately so. So we have to be very, very careful. And I think it's worth investing the enormous amount of money it will take to make schools safe. I've heard estimates of hundreds of millions of dollars for Ontario to make schools safe, meaning you hire more teachers to change that student-teacher ratio. You hire deep cleaners. You rent larger facilities for spacing out in classrooms. You do what you can. I think we can buy our way out of much of this. It just takes political will to throw the money at the problem. But if you're going to spend money at something, this is what you spend money on.
A question to both of you, the same question actually, and let me start with Professor Deonandan. What are you looking for as kind of the green light for schools reopening? Is there a level of infection, a level of transmission, and you say, hey, you know what, if we're within this band, we're okay?
I'm hesitant to give an overt answer. I've mentioned those three metrics already. I think I will continue to look at those three. And I will say that I want the reproduction number to stay below 1 for the entirety of the next 6 weeks. I want the number of new cases to continue to stay the same, if not diminish. And I want the percent of positive tests to be less than 2%. Right now in Ontario, it's about 0.5%. In Manitoba, it's 0.16%. In Atlantic provinces, it's even less than that. So we're doing well on those fronts. So if we can just keep things the way they are now, I think we can open up in the fall, assuming we make the investments I mentioned. But if things go in the other direction, then we have to revisit that assumption, which is why this bar thing makes me very concerned. I don't want to see a handful of sectors being opened up, changing those metrics in such a way that we have to revisit our fall plans.
Dr. Evans?
Yeah, I totally agree with my epidemiology colleague. He's hit the nail right on the head. And I think the other thing that's going to help us move forward and inform us about where things are heading is looking at the experience in countries where there have been school openings to see if we can identify factors that are important in what happens with eventual transmission occurring. And, you know, Israel has had some experience now. In the UK, they've had schools open. They've had now some 49, I think, outbreaks that have occurred that seem to be associated with schools. So we have to dissect that information apart. We have to figure out what that's telling us, and that'll help to better inform all of the things that we need to do when we reopen schools.
But Dr. Evans, I think back to, I guess, a couple of the pub owners that we talked to earlier in the program, not to put words in their mouth, but what if people in that business were to say to you, both of you, that you're being too cautious, that it's not about taking no risks, it's about balancing, you know, risks in terms of opening up commerce and social life and taking calculated risks. Are you, Dr. Evans, being overly cautious here?
I don't think so. And I look to the south of us to sort of suggest to people that you have to be very, very careful. When this disease explodes out of scenarios where there are some establishments and practices within our society, it can explode. And, you know, what's driving that explosion in the United States is, in fact, those social type gatherings, the super spreading events that Professor Deonandan was talking about are very relevant. And those are being driven oftentimes by young people in social situations. And those are the things that are going to change the rise in new cases. The reproductive number is going to increase because those act like super spreading events and they result in large numbers happening. So, and I think I can't underscore this enough. I mean, certainly as a physician, I recognize that we know that the infection fatality rate and the case fatality rate, which is what we have more numbers on, is very high in older people and less in younger people. But as was just stated, young people die from this. And young, healthy people die from this. And we're talking not just about children, we're talking about youth, adolescents, and even young adults. And, you know, I think society needs to put that into perspective. This is not something that's going to be acceptable. And when numbers go really high, like they are in the States, which is just exploding, you are going to see that impact in that particular population, which everyone would agree is just a tragic, tragic thing to look at.
All right, let's take some calls now. Dr. Evans and Professor Deonandan will be with us till the end of the hour. And there's time to call in 1-888-416-8333, 1-888-416-8333. Michelle Joseph is calling in from Toronto. What's your question?
Yes, hi. This is a question for both the guests. I was in line at a takeout restaurant, and they had some tables set up on the sidewalk in front of the restaurant. And I noticed a turnover at the 3 of the 4 tables. People turned over. There was no one to wipe the tables down. How risky is that? People take their masks off. They eat. They're touching the chair back. They're touching the table. They're touching the ketchup. They're touching the salt and pepper. Should all that be wiped down after someone gets up and leaves?
Dr. Evans?
Yeah, well, here's the quick answer. Yeah, they should be wiped down afterwards, and those are part of the protocols that should be in place in any establishment that's in the hospitality industry. But it goes to the issue about fomite transmission. And we know that, like many of the respiratory viruses, fomite transmission, that is transmission through an inanimate surface, can occur. But what we're beginning to see as we really examine the contact tracing of cases around the world is that significant percentage, 80 to 90%, is respiratory droplets. So it's contact with someone who's infected in close proximity where those respiratory droplets can be inhaled and impacted your upper respiratory tract. Fomite transmission, which traditionally with some coronaviruses is as high as 20 or 30%. With this disease, it seems to be 10% or less. So I guess it has to do with, we know that the fomite transmission issue is there. It's important to address with proper cleaning. But it isn't a major driver. The major driver of this infection is these large respiratory droplet spread, and we know that from epidemiological data.
Okay. Let's go. Go ahead.
I was just, so if people take their mask off to eat, are we exhaling vapor that could potentially land on the table or the tabletop or the chairs or whatever?
Yeah, so absolutely. Large respiratory droplets fall with gravity. They're usually greater than 5 microns in size, and gravity makes them fall usually within about a meter to 2 of someone who is expelling them. The question then becomes, how long is a viable infectious virus on that surface? And we've got lots of studies that have looked at components of the virus, like the nucleic acid, the RNA of this virus, and can find that. But studies that have looked at actual virus viability in various circumstances are more limited. We know that in a very heavily contaminated area, like in a change room in a hospital where there's lots of COVID-19 patients, you can find some viable virus in some of those areas. But the question is whether there's enough virus on that tabletop from somebody who may have been infected and was eating there. We still don't know the exact answer. And I'm not suggesting that fomite spread doesn't happen. I just recognize that when we look at cases we can identify, fomite transmission appears to be, around 10% or less of transmissions that are showing up.
All right, Michelle, thank you very much.
The theaters have closed, but the show will go on.
Play Me Podcast is thrilled to present a new series, The Show Must Go On, featuring provocative productions from some of North America's most acclaimed creators for the stage. Sit back and experience everything from chilling thrillers to gut-wrenching dramas to irreverent comedies.
Each month, experience the exhilaration of theater from the comfort of your own home. Play Me, available wherever you get your podcasts.
Hi, I'm Leah.
And I'm Phelan. You know us as the hosts of the podcast, The Secret Life of Canada.
And we've got an exciting bit of news for you.
We do. We want to go to school with you.
That's right. We are now part of the curriculum in a way. We've teamed up with educators from across the country to create teaching guides that go along with some of our best episodes.
We've got teaching guides for Indigenous history,
Caribbean Canadian migration, Black history, Asian history. It's very exciting.
It is very exciting. And so each guide comes with ad-free audio, transcripts, lesson plans, slideshows, and a whole bunch of other stuff.
Yeah, just head to cbc.ca/teaching guides for more info, and it's free.
It's free.
Let's go really cross-country now to Dawson City, Yukon. Duncan Spriggs calling in. We'll put your question to Professor Deonandan. Duncan?
Hello?
Hey. What's your question? Yeah, you hear Ian, I hope, and let us know what your question is.
Oh, well, we haven't had a COVID case within 300 miles of Dawson City. And to go back to the Spanish flu, apparently it never reached here either. However, what would your recommendation be for a town that has no resistance to COVID, that has yet to experience it.
Professor Deonandan?
Yeah, I mean, it's good. It's good that you have no cases. That's fantastic. Let's keep it that way. So it would be horrible if COVID found traction in your community, because the healthcare facilities in your community aren't the same as you'd find in a very large metropolitan area in the South. So it's imperative that we keep it out. That's why you shouldn't be lax about the public health infrastructure and guidelines, as some may suspect you'd be encouraged to be so. So wear a mask indoors, continue to hand wash, and distance. You should be confident, not afraid of your fellow person. Don't panic because the disease is not prevalent in your community, but let's keep it that way. That's my message. If it's not there, keep it out.
Well, I'm one of possibly 3 people in town that actually wear a mask going into the grocery store. You would not know from the behavior of people in the town that there was any problem or potential problem at all. How can we get this across?
This is the biggest question.
I was talking to the Premier the other a week or so ago, and he said, I asked him why there weren't masks and hand sanitizers outside every business. And he said there aren't enough masks to go around.
All right, Duncan, let's hear from Professor Deonandan.
Yeah, this is the fundamental challenge we're experiencing right now in public health communication, is how do we get the point across that this is not about individual risk, it's about population and community risk. The risk to each of us individually is actually quite small, because right now the prevalence of the disease is quite small, and the probability of anyone getting it and therefore dying of it is actually relatively small. It's not zero. I'm not saying we should take it seriously. Of course we take it seriously. But when this is scaled up to a population level, it's a devastating disease. So it's making that switch between communicating the selfish elements of individual risk, what does it mean to me, to being more community minded. How do I keep my community safe? And I have no obvious solution to this. It's what I struggle with every day in talking about this disease. But what I do is I encourage people like you to take up the roles of community leader, of expressing your concerns and your fragilities and vulnerabilities to your neighbors and to your policymakers. If everyone has a loud enough voice, I think we can make some change happen. There are other things you can do as well to protect yourself in the meantime. Masks in general protect the other people. We wear a mask to diminish outward transmission so that incrementally the community caseload goes down. If you wear a face shield, you're adding some inward protection. So you're protecting yourself now as well. So if you're concerned about yourself, wear a mask and a shield. But your question is about how to create change in your community, which is an excellent question. And that the answer for that is you enable and empower people in your community to speak up and use their voice.
All right. Thank you very much for that call. And let's go on now to Carol Bevan in Ottawa. You have a very specific question, and we'll put that to Dr. Evans. Carol?
Hi. We purchased a business class ticket for our 37-year-old son to fly from Vancouver to Ottawa to visit us at a cottage for 1 week. My question is, should he get on that plane?
Yeah, so it's a great question. I think this might be the number one question I usually get asked by assorted colleagues and staff at the hospital and university I work at. So one of the things we know is that if you wear a mask on that flight, and certainly I would be encouraging that significantly to try and reduce that risk by increasing barrier protection. In a business class area, I don't get to fly business class. I'm only a doctor. The spacing is potentially far enough that that's going to add some further protection. The other thing that we've learned about is that on planes, at least modern day aircraft, the ventilation system that use has HEPA filtration, and that is going to significantly reduce certainly large droplets that might be expelled should there be someone on that flight who actually is infected and is shedding the virus. So I guess my advice generally would be, I think if you're going from an area like Vancouver where there's a fairly low prevalence, flying into Ottawa where there's a fairly low prevalence, that's probably not a huge risk. And I would certainly encourage mask usage and as much physical distancing that your son can do while he's on his travels through the airports, et cetera.
I'll just jump in though,
Okay.
Dr. Evans. So
Sure.
that's a business class ticket. Now we're hearing that we're hearing WestJet and Air Canada will start, have started seating people in all the seats. So in economy, that could be 3 in a row. If you're in the middle seat, how safe are you?
Well, if the person next to you is shedding the virus, you're less safe than you think you are. I must say, I have not been particularly favorable about the idea that we're at a point where we can now start to fill up that third seat in any row. I think maintaining some distancing, even in economy class, is incredibly important, and it sends the right message. And I think, frankly, the airline industry is not sending the right message with that sort of setup. But again, as I said, there are some other factors that come into play, including the ventilation that occurs in modern aircraft.
And Carol, I think I interrupted you. Did you have a follow-up question?
No, that was very helpful. And we've been very conflicted about this. And just hearing that was more encouraging.
All right. Carol, thank you very much for calling in. A question, or I guess a comment, via social from Jones Store. If the driver of a car is wearing a mask and I sit in the back seat wearing a mask, are we both safe from COVID-19? Professor, what's your sense of that?
I think you're safer than if you weren't wearing masks. It depends how long you're in the car for as well. So the probability of transmission, Dr. Evans and I are actually having a conversation about this on Twitter offline seconds ago. The probability of getting the disease is related to the duration of exposure, the intensity of exposure, and the probability of people having the disease in the community. So if you're in a society where the caseload is low, like the Yukon, it's unlikely that either one of you has the disease. If you're both wearing a mask, it's unlikely you're able to spread it more than a couple of centimeters beyond your face. I think it's the risk is very, very low, if that's the case. Just don't touch a lot of surfaces and touch your face afterwards.
Let's continue this mask theme, and Richard Benke is on the phone. Richard, thanks for calling in. What's your question?
Hi, yes, thanks for picking me up here. Gentlemen, it's my opinion that you have got to learn to define what a mask means and not use that stupid phrase that's made its way into half the ads where it talks about face coverings. What the hell is that? There's nothing the same between putting a Lone Ranger kind of mask around your nose and what you're talking about as a proper mask. It should have a definition, a standard to which it goes. We haven't got that. So as long as we don't have any standard, we'll always have trouble talking about masks.
Do you wear a mask, Richard, when you go out?
When I go on the street, no. When I go into the businesses or indoors, yes, of course, the law demands it now.
And what kind of mask do you use?
It's one of these, it's titled as a medical mask, those blue cheap things.
Yeah, okay, yeah, the ubiquitous blue mask. I know them well. Dr. Evans, okay, I'm going to put this on your shoulders. Define mask for us. Come on.
Absolutely, no question about it. So this, I it's very important because one of the other things that's talked about a lot are N95s, and they're not masks. They're actually called respirators. So that's mask, we're talking about a mask which covers your nose and mouth. Fortunately, now what we've seen is organizations like WHO and the CDC have now issued guidance as to how to make a cloth mask or a fabric mask. So that's actually great because, of course, people were making masks now for many months and they were using various scraps of material they had around. And so they've now introduced the concept that it should be 2 layers. That you could introduce a pocket. It should be made out of cotton, which allows you to make a mask that has less sort of large holes in it and allows the retention of respiratory droplets. Outside of that, what we're usually talking about are medical grade masks, and they come in varying levels. They're actually marked in levels by the fact that whether or not they're moisture resistant or not. So we have level 1, 2, and 3 masks. Most of the masks that you are picking up that I think was Connie mentioned, the light blue ones. By the way, the color code is very poor. Don't go by that because some of them are yellow and some of them are blue, but they actually mean the same thing. But those tend to be what we call level 1 masks. Some of them don't actually have that rating, but they're actually very effective. They're as good, if not a little bit better than a cloth mask, even a cloth mask made to perspective. And once you get into level 2 and 3 masks, you're talking about very high level medical grade masks. These are very effective in preventing transmission to the person who's wearing it, In addition, that it would obviously provide a substantial amount of prevention of spread of droplets from someone who's wearing it, who is a source person. So medical grade masks are great. We're fortunate in getting more supply of those coming into the hospital sector, and they're what we're tending to hold on to and trying to hoard in the eventuality that we hit a second wave or subsequent waves, and we need those for people who are working in the healthcare side, like I work in acute hospital care. So a mask is it's not a Lone Ranger mask. I think they already got Trump on that one, but essentially it's a mask that covers your nose and face, and of course it only works effectively if you cover both your nose and your nose and your mouth. I said face, I meant to say mouth.
Yeah. All right. Thank you very much for that call, and thank you, Dr. Evans, for clearing up what a mask is and the ones that we should be thinking about getting. We are in the Ask Me Anything portion of the program as we talk about COVID and infection risk, and Joanne Woods is our second caller this afternoon from Sault Ste. Marie. Joanne, what would you like to ask?
Well, I am a school bus driver. I've been driving for a long, long time, and I've heard a lot of discussion about keeping kids safe in the classroom, but I haven't heard anything about when we're transporting them to school. We have typically our day we pick up our high school kids, then we go right into an elementary section, then we go right into a French immersion section. Different schools, different children, all day long. And I've heard nothing about getting the kids to school. I've heard a lot about when they get to school, what's going to happen, but I've heard nothing about getting them to school.
Well, I'm trying to alternate the questions between our two AMA experts. So, Professor Deonandan, let me put that to you.
It's an excellent question. And when I mentioned earlier that we need to spend money in large amounts to solve this problem, that's one of the things I think we should spend money on. Buy new buses, hire more drivers, cleaner buses, smaller buses, whatever it takes in order to get the kids to school in a vehicle that has as few of them as possible. Now, we have models to follow. The Japanese have been busing kids to school during this pandemic quite successfully, and there's some adorable videos you can see on YouTube of little kids getting on buses with their masks and face shields on and greeting the bus driver who's protected behind plexiglass. So there are things we can do, and other countries have shown us how to do it. But the caller is absolutely right. Transportation is one of those areas we have to focus on. So it's kind of related to the question around airline travel. We focus so much on what happens in the plane, but it also matters what happens in the airport and transportation to the airport and getting in and out of the plane. The same with the schools. Transportation to the school, getting in and out of the school, and how to protect the drivers and the teachers and the custodians and the people who serve lunch. All of this is part of this expensive package that requires us to really invest a lot of time and resources right now to get it right.
Joanne, thank you very much for your call. This next call actually is going to fit right into that theme in terms of there's, sometimes as you wait for things, that can be as risky as the thing that you're waiting for. We have a nurse in Calgary who's calling in. She wants to stay anonymous. So we're going to call her Ellen. And what's your question this afternoon?
Thanks for taking my call. I work in a community living healthcare facility, and we're quite diligent about testing people and questioning them on their COVID symptoms twice a day. However, we get into trouble when a person identifies a symptom associated with COVID-19, and then we take a test. So in our facility, patients are usually 2 or 3 to a room. And because of our physical size and our always full occupancy, a couple weeks ago, we had to put 3 patients who had all identified COVID symptoms in a room together while they awaited their test. So they were in there almost 24 hours a day, just wearing the surgical procedure masks, and then had to go outside of the room to use a bathroom that they again all shared. So my question is, what I feel that I'm worried that not all of those patients might have had COVID, and we had some vulnerable people there who could have been at risk of getting COVID unnecessarily. So I'm wondering, am I in a unique situation? Are there other places in Alberta where we have similar issues like that?
Dr. Evans?
Yeah, she's identifying a real problem that we have in community living spaces that are congregate, and that is the ability physically within those facilities to separate people while you're waiting for test results to come back. What they ended up doing is they cohorted them based on symptoms. That is, they brought a group of people that they thought were similar in one setting, but they didn't have test results. And it's quite possible that one of them was infected, the other two weren't. Once you put them in together, then there's a risk for transmission that's going to increase just based on that sort of time and intensity of exposure with someone else. And it's the challenge, and it's been the challenge that we've now identified in long-term care in general across the world, because the long-term care settings that exist everywhere around the world pose all these same problems of just not enough sometimes space in order to separate people out. As an infection control individual, I think any place where you bring people together, whether it's an acute care hospital, a chronic facility, a congregate community living setting, or long-term care, they should all be single rooms. And then you don't have to worry while you're waiting for a test to come back that individual has been put somewhere else. So she's really putting forward, I think, a very significant problem that we are going to have to address moving forward. And I think I've been certainly a vocal proponent that we've got to address what we're doing in congregate settings. And the one that sticks out the most, of course, is long-term care. Bit of a problem.
Well, I appreciate the call from, we're calling her Ellen, a nurse in Calgary who wishes to stay anonymous. And thank you very much for all of the expert advice that we've received from our two guests on the Ask Me Anything, Dr. Gerald Evans, chair of the Division of Infectious Diseases at Queen's University and the medical director of Infection Prevention and Control at Kingston Health Sciences Centre. He is in Kingston. And Raywat Deonandan, an epidemiologist and associate professor at the University of Ottawa. And that's where we reached him.
For more CBC podcasts, go to cbc.ca/podcasts.